study. As Renee has pointed out, that I am with the Department of Global Health and Division of Health Systems and Public Health here at Stellenbosch. In the past 6 years, I've also had the privilege of serving in the health market inquiry. And my interests in general, besides that, include conducting economic evaluations of health interventions, looking at inequality on health outcomes, and the use of community health workers. I'm trying to move my slides, but okay, great. So today I'm just going to cover the background to this study, talk about why we needed to have a coronavirus rapid mobile survey, and the evolution that we went through as we were designing the survey, how we made it happen, the sampling strategies we used, our findings, recommendations, as well as how we have disseminated the findings. I think that we've learned from the Ebola outbreak that there can be unintended health costs of fighting pandemics. And those unintended health costs can be at times just as high as the cost of fighting the pandemic, or even be greater than the direct costs of fighting the pandemic. We learned from the Ebola outbreak that the consequences of fighting that outbreak included reduction in access to maternal and reproductive care, as well as neonatal care, and that in fact the deaths from a reduction in access to this type of care were higher than the deaths that were actually recorded by the outbreak. And so being confronted by the coronavirus pandemic, that very little was known about it in terms of its social impact, we thought that in order to be of value to government and to society, we needed to actually do something, and the contribution that social scientists or economists could make in this instant was around providing good and accurate data to aid decision making. However, we needed to do this in a context where information is changing rapidly, where one can no longer easily go into people's homes and administer questionnaire. So we were faced with a need for rapid information and information that needed to be accurate on health outcomes, social outcomes, as well as the economic outcomes. The second need was around having information that would be nationally representative of the South African population. We know that there are traditional forms of data collection that are representative of the South African population, such as the quarterly labor force survey, the National Income Dynamics Survey, as well as the General Household Survey, which do cover some of the topics that we thought were important. However, administering these studies in the traditional way would not be feasible because they require time as well as a face-to-face interaction. And so that was really the motivation around that we need a rapid coronavirus survey. At the same time, questions were emerging about the need to understand the unintended consequences for health services. So at the same time as we were thinking about finding a nationally representative sample, we were also having informal discussions with key policymakers, including Peter Barron and others, about the need for understanding unintended consequences of our work around the end of May. And through those engagements, we identified a Mom Connect sample as an avenue to answer these questions in parallel. I think it's worth mentioning that also we received immense support from our ethics team here at Stellenbosch, and we have deep gratitude to Len Hansen as well as Samantha van Schalkwyk for rapidly reviewing the proposal and I think within 24 hours and getting back to us. I think another process that also went rapidly was the approval to access the Mom Connect sample by Dr. Leslie Bramford from the National Department of Health. And thus we were able to then finalize the instrument. Following that, other processes that also received urgent support were the approval of the budgets by Alan Gray Obis Foundation and contracts signed by, between Prakeld and Achof, and for that would like to thank Jane Passmore. And so we proceeded with a stratification strategy and draw the sample and the survey was conducted between the 24th and the 30th of June. I think it's worth mentioning that we're working in really uncertain times, and while at one point one can make plans of when you would start, we actually had to also include some degree of flexibility. So initially, we had planned that the NIDS CRAM survey would start on the 6th of April, and that we would have 6 waves every 2 weeks for 6 months. And it would be a short survey of 10 to 20 questions. However, eventually the survey started on the 7th of May, with the first wave of field work ending on the 27th of June. Given the wide impact and long duration of the COVID pandemic, the design has been amended now to 5 waves over a period of 12 months, and thus the survey will run into 2021 and also consider economic and employment recovery as well as the social response. Given all that we wanted to know, we ended up being able to have a 20-minute survey covering questions around employment, grants, social grants, hunger, and health. It took exactly, I think, about 114 days from the first conversation around the need for evidence on the social impact of COVID-19 to the 15th of July, where the findings were released as well as the data. And in this slide, we just sort of show all the different stages that we went through and the timing. And I think that it's really important to note the rapid fashion in which all the stages were completed, and that wouldn't have been possible without the collaboration and willingness to participate from all the different partners, some of which I've mentioned. So the first block shows the evolution and the timing for NIDS CRAM. I think in the previous slide, I had shown that we identified an additional data set that we could tap into, which was the MomConnect data set, and the timing of identifying that and being able to actually include it to our study, which in total amounted to about 57 days, including all the approvals that were needed and the budget. And below here, we just show the different stages of lockdown that the country was in. So the team behind the work, I think, as I've been saying repeatedly, that it wouldn't have been possible without a really heroic collaborative effort that was spearheaded by the multi-talented Dr. Nick Spall, with broad participation across disciplines and institutions. So, for instance, we pulled together about 30 social scientists, researchers that were involved in the core CRAM team, and with 8 researchers from Wits University, researchers from Stellenbosch University, UCT, as well as UWC. On this slide, you're seeing all the people who were involved in the health aspect, in the health module of this work. Other researchers were involved in other aspects of the work, such as the employment and other stuff. So how did we conduct our sampling strategy? As I've mentioned, we had the need and the desire to have a nationally representative sample. And so we pulled on what we call the National Income Dynamics Study. This National Income Dynamics Study was initiated in 2008, and it covers all South African individuals together with people who live with them, and within that sample, in the first wave in 2008, there were about 28,000 individuals, and the sample has the study is now on wave 5 and has suffered 4 rounds of attrition. So by the time that we were thinking of using this study, we no longer had the 28,000 that was available in 2008. Nonetheless, for the coronavirus rapid mobile survey, we were able to pull 7,074 individuals who would be interviewed using mobile phones. And each participant received an incentive of 20 rands a time. As I've mentioned, alongside this NIDS CRAM study, we identified that we could explore in depth questions around maternal and child health by tapping into the MomConnect database. According to Lefray, in 2017, there were more than half of the women attending public sector antenatal care are registered on this Mom Connect platform. And so we then drew a self-weighted sample of 15,000 pregnant women. And then within that, assuming a response rate of 20% from the target sample of 15,000 women, we aimed to achieve a survey sample of 3,000 rands. Sorry, of 3,000 individuals. In the end, we ended up with a sample of 3,140 pregnant women and new mothers. So we actually achieved a response rate of 21%, which was slightly higher than what we had predicted, and we were very pleased with that. So now I'm going to move into the findings, and the focus of the findings will be on the health papers. So we covered on the health aspects, we covered the risk and perception and knowledge and behavior. We also examined unintended consequences of the COVID-19 pandemic, as well as the income-related health inequalities that are associated with COVID-19 in South Africa. So the first key finding under the NIDS CRAM wave 1 sample was that only 1 in 3 are implementing the most effective preventative measures. 91% of the respondents reported changing their behavior in some way to try and prevent contracting or spreading the virus. As you can see on this diagram, that the first, I think it's worth mentioning that this was one of those questions where a person can answer more than one question. So each bar is out of 100. So there was about 35% of the first best behavior changes, and then 53% of those who reported that they changed their behavior, reported that they were wearing masks. 58% of those people who also reported that they're changing behavior reported that they are avoiding people, and then only 25% reported that they were maintaining the physical distance. We of the view that this is too small a share. There's too small a share that are complying with measures that can change the trajectory of the disease. To have the needed impact, at least 8 in 10 need to wear masks to change the trajectory of COVID-19. In terms of knowledge, knowledge about the 3 most common COVID-19 symptoms is limited. Again, in this diagram, each column represents a percentage out of 100. So for instance, 66% identified coughing as a symptom for COVID-19, and then 63% identified fever as a symptom, and then only 11% identified tiredness or weakness as a symptom. And the last bar represents those who knew all the 3 symptoms. And it's low because of that there were fewer people who could identify tired or weakness as a symptom. When we asked people about their information sources, we found that the 3 most trusted sources of information are the media, government, and health workers. And that the media is by far the highest, with 80% of respondents trusting them, while 14% said they were visiting government websites or WhatsApp groups. 11% said they trust information from health workers. I think it's worth noting, though, that those who relied on health workers and government sources for information had more accurate knowledge of symptoms and tended to choose high impact preventative behavior methods. In terms of the effect of COVID-19 on healthcare seeking behavior, we found that almost 96% of those with chronic conditions received the care that they needed even during the lockdown. And the most common cited reasons for not seeking care was largely the fear for contracting coronavirus. So on this diagram, again, you have percentages, and we've compared acute and chronic care. And at the bottom, you have the reasons for not seeking care. And you see that the being afraid of the coronavirus was one of the most cited reasons. However, this reason stands alongside other factors that we've known to impede care in the South African context. So, for instance, the long waiting time, no money, and no transport. So even though the no transport is a factor that existed before COVID-19, but we think it's worth noting that at the time that we administered these questions, it was a time where transport arrangements were still limited and had restrictions under, I think, level 4 lockdown. Now we shift it to findings from the Match 1 data set, and remember that the Match data set is the one that tapped into the MomConnect database. So we found that 1 in 10 mothers are not accessing ARTs. We found that 1 in 10 mothers ran out of their ART treatment in May and June. And we think that this is a very concerning because the interruption of the ART treatment risks the health of the mother and also it increases the risk of mother-to-child transmission of HIV if the mother is breastfeeding. So the reasons for running out of ARTs, also high, about 40% of the mothers who ran out of ART and didn't go and access them cited a fear of getting the coronavirus. I think the next largest reason cited was no ART available, followed by transport problems, waiting time, and others chose not to answer that question. We found that also 1 in 6 mothers and pregnant women reported at least a 2-month gap in care. And this included 1 in 4 mothers who needed vaccination. We asked mothers when last they had gone to the facility, and we also had their predicted due dates. And so on this pie chart, you see we've highlighted the 16% that have not been to the health facility in June or May. And we think that this is important and concerning, given that in part of the quadruple burden of disease in the South African context includes a high maternal and high maternal mortality as well as infant mortality. And though South Africa in the past decade has managed to make considerable grounds when it comes to infant mortality, we think that we really do need to keep an eye on this so that those gains are not reversed. We've also found that the impact of the virus was experienced differently by people in different socio-economic status. It's worth mentioning in this slide that we had the Mom Connect database has pregnant women and new mothers who are accessing public health care services. Therefore, our distinction between the poorest 20% and the most affluent 20% does not represent the typical distribution in the South African context. It is the distribution of mothers who are accessing public health services. And so that most affluent is not the most affluent in South Africa, it's the most affluent within that group. So looking at the subsample of mothers who did not access care for 2 months, again, fears around the coronavirus were more pronounced, in particular for the poorest 20% of this population. Again, long waiting times, again, was more pronounced for the 20% most poorest in this population. And we could conclude that all the varied factors, with the exception of no need and others, but the sort of key factors that affected people not accessing the care disproportionately affected the poorest in this group. So we'd like to draw to your attention a few limitations that or factors that should be borne in mind when interpreting the findings, in particular of the match wave 1, which is the survey that drew on the MomConnect database. That eventually we had a small sample, and we have some concern about selection into the MomConnect and also selection into responding to our survey, that there might be an element of selection bias. We therefore see our results as complementing existing information from administrative survey that tell us that there is a drop in attendance, but cannot identify the reasons for this drop. We also looked at high stakes types of services where the impact on treatment or care interruptions are high. So for instance, pregnancies and young babies. But this may also mean that interruptions may be far less likely than for other types of services. And lastly, we know that samples become very small when we look at reasons for not consulting, because it is a share of those who did not consult, which is already small. However, we found overwhelming evidence across all our service types that coronavirus fears were the #1 reason. So we feel that this is robust despite these concerns that we have outlined here. So we've recommended that we need to deploy community health workers more effectively as service linkers, and in particular also to address knowledge gaps and perceptions around risks and fears on approaching health services. We think that there is a need to strengthen local coordination structures to ensure local ownership and champions. And I think that this would really strengthen changing of social norms. We think that there should be a distribution of free masks to the poorest communities. Not all citizens who need a mask can afford the appropriate face masks. And we think that the distribution should include information flyers that outline the symptoms as well as all the different measures of prevention. We've provided specific and actionable recommendations on key preventative behaviors, such as the focus on wearing masks and physical distancing, and clear and concise and consistent communication to improve knowledge of the most common symptoms, especially weakness and tiredness. And perhaps in particular, I think for the media outlets to anchor messages in hope and a positive vision for the future, instead of relying on fear tactics and scaring people. So what did we do with our findings? We disseminated the findings to policymakers and as well as various activists. There was a launch, I think on the 15th of July, on the findings of the whole study. The findings were shared with the National Department of Health policymakers, including the Minister and as well as provincial decision makers. Altogether, the CRAM generated a lot of media coverage, including articles in international press, and locally the health findings were covered in Spotlight, Financial Mail, as well as ENCA and all the others listed there. This is just a selection of the few articles that were featured on the media outlets. So what is next? Currently, NIDS CRAM Wave 2 is in the field. It started on the 22nd of July, and it will end more or less, I think, on the end of August. So thank you very much for your attention, and we can take questions now. I think Ronel Berger, who was the lead for the health team, is also online, and there may be other NIDS CRAM colleagues, and so we will take questions as a team. Thank you.
So thanks very, very much, Dr. Lungiswa and Nkonki, for an excellent overview of this very important study. And a few things come to mind, such as translating of the evidence into policy and practice and the hows around that, as well as the very important aspect of managing this pandemic, which is around messaging. And I think your work certainly provides evidence that I know certain policymakers and practitioners are looking for. As you had alluded to, there's Ronel and possibly some of your other colleagues on the line or on this webinar. So if any of them have anything to add, please go ahead, raise your hand, and we'll allow you to make your comments. And I would also encourage the participants to please type the questions into the question box or raise your hand so that we can have a discussion. Thank you. Ronel, not to put you on the spot, but do you have any contribution to make to this?
I think it was for us quite interesting and surprising to see how low the levels were of compliance with social distancing and mask wearing. And I think that given how clear it's become that the trade-offs between the economy and saving lives are stark and how terrifying that is, I think we should, the clear win for both of those dimensions is that we should do more on the prevention side. So I really think that it's important that we exert as much effort as possible to try and prevent cases without sacrificing jobs. So allow individuals to work, but to work safely, and promote that and enhance sort of protection and prevention by thinking through ways in which we can improve mask wearing. I think I'm worried also that putting the burden of mask wearing on shop owners and owners of buildings, I think we need to do more. And I think I'm very partial to more community level, community-based efforts to ensure that there's a very clear understanding of how effective the masks are and how big a difference they can make, especially if there is a very high level of compliance, and to tap into the social solidarity that we're wearing masks for one another, I think is something that I really am getting behind and that I feel very strongly about.
Renee, I think you're on mute.
Thank you. Thanks very much. That sounds like Jürgen. Am I correct?
Gaurang here.
Gaurang. Hi, Gaurang. I'm so glad you're chatting, Gaurang. So Gaurang Tana is from the NDOH and leads a lot of our processes, particularly the aspects around the digital aspects of managing and preventing the pandemic. Gaurang, would you like to add to this? I think the issue around messaging is very important, and also the policymakers' response to this kind of research.
Thanks, Renee, and thanks for the opportunity. I think, and thanks for a lovely presentation. I think I couldn't agree more with the previous. I think it was Prof. Berger who commented. I couldn't agree more with her. I think the big problem we have with this pandemic, and it's really showing up, is this social behavior change communication that I think is very, very much necessary. Are the primary prevention measures and really difficult to get around. What was very, very interesting from the presentation, if I can pick up one slide, and that was the issue where I think the source of information that people trust, 80% media, 13 or 14% government and WhatsApp channels, and slightly less, I think, another group. I think that was a very, very interesting finding, and goes to show how important communication through media is. What would be very useful to try and understand is if there was any disaggregation feasible between print media, social media, and other forms of digital media that could be measured through that. That will give us enormous insight into how best to enhance that. Over.
Thanks very much. Lungiswa, Ronald, would you like to respond?
I can start with the answer. That does present just print media, but all types of news media. We had separate analysis for social media. So I agree with you fully. I think it's really important and interesting that we find that while most of our respondents were reliant on news media for the information, overwhelmingly, it didn't seem to correlate well with understanding how best to invest your energy or with knowledge of the disease. As we find that using government sources and using getting your information through health workers do seem to correlate well with better knowledge and a better idea of how to use your energy well, using masks and social distancing. And I think that is a puzzle and something that we need to investigate deeper. Why is there such low reliance on government and health workers as sources of information about the coronavirus? Is it coverage or is it trust? We need to unpack that and understand it better, because it seems to be a key channel to better information and better compliance.
Thank you. Can I ask a question in terms of how the policymakers responded to some of your recommendations? So you speak about this broad audience that you accessed, and at the end of the day, it's the policymaker who responds to recommendations like increasing distribution of masks, and then addressing aspects around the fear, which Gaurang touched on now in his presentation. But I think that aspect of how do we deal with the fear and how do we improve services. You also touched on issues around community health workers. So what were the responses to that?
I can start, and then Ronel can add to that. It was very positive. So, for instance, Nicholas Crisp, who's the key advisor for the National Health Insurance strategy, immediately when we shared the results with him, sent it to the various provinces and said, this is the type of knowledge that we know anecdotally, but we actually didn't have the sort of empirical evidence to back it up to move us forward. So it really has received a positive response. We've shared the findings with schools of public health, UWC, UCT, and others, as well as the head of health here in the Western Cape, Dr. Keith Kloot. So it's all been very positive. And then I think the other important aspect of our collaboration and partnership has been the inclusion of civil society. And so I think even in our health team, we have Russell Ransbeck, who's part of the rural health group. So we are also in touch with them in terms of the actions. So we've tried the best we could to inform all key policymakers and those that we view as policy enablers, such as activists and those working within the civil society.
Thank you. Prof. Chicta, I see you have a question. Over to you.
Yeah, sorry, I must have had my hand up and down because I was playing around with this thing. But the question that I have is related to what Lungiswa just spoke about now, what she calls the involvement of civil society. So the question is really, and thank you, Ronel and team for working on this. But the question is, how does one do research in this COVID era, and the extent to which one engages people who are affected most unequally by it, and the nature of the questions themselves is, I mean, there's a whole debate around how the lockdown in South Africa has failed because in terms of its constitutional obligation of how to consult, that consultation didn't take place. And the impact on that, whether South Africa and India, has been, there's been an inordinate impact, negative impact on this. And to what extent can one engage the population in the kinds of questions that we are raising, finding out what needs to be found out and translate that elsewhere. The kinds of questions that we ask, the participation, was there any attempt in this questionnaire to say, what is it that the people want? What is it that people on the ground want in terms of transport, access to medication, and the whole issue around masking? The way I understood it, the way it has been framed is, differently from the conflicting messages that were provided in terms of masking, wearing of masks, in terms of transport, in terms of opening up the economy, in terms of going to school. So, I'm just wondering, in terms of the first question, Renee, and you will appreciate it more because of your involvement, how do we do public health research or research differently now that this thing has been flicked up? Thank you. I need to go to another meeting. That's why my hand was up and down. Thanks.
Ronel will go first. Thanks.
Okay. Thank you, Yusuf, for this question. I think this is part of what we've grappled with and why we wanted to do the survey, because I think in this environment where we really need to understand what people are going through and how this enormous pandemic is affecting all of our lives differently, to understand the pain, the suffering, and the heartbreak, and to know how to best respond to it. We need to speak and we need to be able to have access to voices. And at this point, we really didn't have access to that because of the lockdown and the physical constraints, and because there's not any medium or channel or platform to facilitate those conversations when one cannot physically congregate and be in the same space and visit one another. And I think that is part of what motivated our survey and why we have opted against the internet survey as other organizations did, because it was really important for us to start with a sampling frame that would include the most vulnerable and the the poorest members of our society. And that's why we're incredibly happy that we could use the NIDS sampling frame that does include a broad and diverse set of South Africans and has national coverage. Unfortunately, because there's so many questions that we needed to ask, and because we were reliant on a computer-assisted telephonic interview technique, we couldn't ask in-depth questions and we couldn't ask open-ended questions. There was just too much pressure and too much information that we needed. But I think it is important that we do engage and that these questions are asked, but I think they might be more suited to open-ended telephonic interviews and qualitative methods. I do also think that part of the excitement about using the MumConnect survey, trying that and using that platform, is that that is a very broad set of users for which we have a way to communicate with them. And I think that also opens the possibility of, in further rounds and further waves of the survey, asking questions and perhaps also complementing the short SMS surveys where one can't get much granularity, detail, understanding, depth, with qualitative interviews where we can start to engage more substantively and get to some of these questions that you've asked yourself.
Lungiswa, would you like to respond next?
Yes, but just to anchor what Ronel has said. So I think with the this type of survey, you can only do so much in terms of addressing all the other issues Yusuf highlighted. So I think this was the first wave of identifying sort of quantitatively what are the knowledge, risks and perceptions, and what are the barriers to accessing care. And I think it doesn't negate the need for qualitative and more in-depth questions, and perhaps also a leveraging of this existing data set. I think what concerned us at the beginning of the pandemic is that we're seeing a lot of internet-based surveys that were not particularly representative of the South African population, who would largely live out public health services users, and perhaps the most marginalized in our communities. So this is one form of evidence that can be complemented and supplemented by other forms of evidence. So I do feel strongly and agree with Ronel that there still a need to do qualitative and more in-depth studies, but that is not going to be achieved by this survey. But this platform can be leveraged to do that different type of research. I just wanted to add one thing, Renee. We focused, the presentation highlighted a lot of challenges, but I think there was also a sort of a positive message in that we found almost 96% of those who needed to see a health worker for chronic conditions such as HIV and TB in the NIDS CRAM survey, they were able to do so or access their medication. And I think that this speaks to some of the interventions that have been adopted in certain provinces, for instance, like the Western Cape and Gauteng, where they have embarked on a chronic dispensing programs. And we think that there is an opportunity sort of moving into the future in understanding how could these new ways of delivering care be used more routinely. What are their benefits? But that this is one positive intervention that we think did assist those who needed chronic medication.
Yes, absolutely, and I think that's certainly one of the lessons in terms of health system strengthening that we can build on at times like this. We are just about out of time. We have one last question, and that's from Sebastian Gelderloom. It says, are you saying that agency was established through government and health worker interaction rather than the media alone? And if so, in your opinion, what is lacking to balance the impact of interactions or communication, so between the two? I suppose the question is, how do we improve communication via the media? I'm not sure if this has come up in your discussions. I think you alluded to it partly.
Yes, I'll deal with it briefly, and Ronel can jump in. I think that we think it's important to have clear, concise messaging. I think in new epidemics and pandemics, it's not uncommon that the information will change as new evidence come to light. So I think that there is no expectation that if there is an understanding of how the disease progress or what the prevention methods are at one point in time, that should stay the same. So we know this during the time of HIV, in particular with breastfeeding, that very early on, avoidance of breastfeeding if a woman was HIV positive was the recommended method. And then as the knowledge base improved, we understood that exclusive breastfeeding is safe even for pregnant women who are on ARTs. So, but the important thing is to be clear when there is that change, and then to communicate the same message across different platforms, and to invite the media to these to findings or to presentations of findings from studies. I think like we did, the study was launched with various media outlets present, and the research team did their best to clearly explain what we have found and what are the implications of the findings. And so we think that it is a very important collaboration that of researchers and media, and but we cannot overemphasize the importance of clear and concise and consistent messaging. Ronel?
Yes, I don't have too much to add to that. I think, you know, to really turn that finding into something that is actionable and that can have an impact, we probably need to understand in more detail, you know, which news media are accessed and trusted, you know, because I think one needs to distinguish between, you know, online, TV, radio, and it's probably a variety, but I think it would be good to do some follow-up work to have a more precise understanding of, you know, if one targets specific news media for improving the content of the information that they transfer, where do we start? Where will we get the biggest impact? And we need to move fast, and we need to have big impact, because I think the trade-offs and the costs that we're seeing realized at the moment are of, you know, massive sizes and will affect the futures of the next generation in a very dramatic way. So I think this is the time to really move fast and think fast, and that's also why we wanted to do the research as rapidly as possible.
So thanks very much, Prof. Berger and Dr. Nkonki, for really excellent work. I think what I would like to conclude with, as I try and wrap up the discussion and hope that this will be one of many discussions around this particular topic, is first of all is around using data to inform policymaking. And for me, some of the important information that's emerged from this particular presentation has been the importance of understanding what the key issues are and then targeting that. So if the issue is there are no masks and people are not able to access masks, and we're doing some other work as well in the communities and found exactly the same challenge that communities have. So there's a will, but there are no resources, is to be able to ensure that we are able to provide the masks to people. Second is, if people have fear of accessing health services, how do we deal with that? And that links to messaging. And then issues around transport, long waiting hours, those are issues that are almost systemic to the health system. They long preceded coronavirus, but coronavirus, the pandemic has certainly brought to the fore these issues that we find within our health system that require us to address it. And those are certainly the intentions of national health insurance as a policy debate, that we would start to address some of those issues. In terms of just looking at it from a future-proofing perspective, again, the lessons there are the opportunities that such a pandemic has afforded us to collect data in a different way and to think about collecting data in a different way, which is resource less in terms of resources and also effective in terms of speed. The second is, how do we best translate information so that not just the policymaker, but the media, the other actors and stakeholders are able to very quickly respond and adapt themselves so that they are able to respond. And then finally, continuity of care, and how do we think in the future around continuity of care? There was mention made of community health workers. But how do we continue that at a time when people are just not able to or wanting to access the health service? And then, as I said, finally, but my last final note is that there are positive stories, and there is hope, and it's the hope and the positive stories that we also have to communicate. So on that note, I'd like to conclude today's webinar. Once again, thank the two speakers, also thank you as participants, and invite you to continue the conversation. We will have a copy of the recording and hopefully also the presentation made available on our website, and you can contact Stacey Blaus. Her name and contact details are on the advert for this, and we will continue to advertise our ongoing webinars. Thank you very much for joining. Also, thank you, Gurang, for your contribution to the conversation. Bye-bye all.